just give a brief overview of who we are that's presenting these series of town halls. So we're the Scripps Hub Academic Research Corps, and we're a partnership between Scripps Health and Scripps Research as part of an NIH-funded Clinical and Translational Science Award. And we just wanted to help bring the different groups of scientists, clinicians, and county leaders together as we fight this pandemic. So this is a three-part series that will be covering first, what is there to know about the scientific updates, clinical updates, and county updates in terms of resources for this. The next discussion will be around risks and benefits of joining the local vaccine trials. And finally, the third discussion will focus on the patient experience, hearing from survivors, learning about how contact tracing works, and also how high-risk individuals can stay healthy during this time. So this event is brought to you by not just the SHARC team, but also the Community Advisory Team and the Health Equity Task Force. So I want to give credit to, my screen will advance. So the Scripps Hub Community Advisory Team, Marty Acevedo, Dr. Susanna Flalo, Carla Corte, Dr. David Higgins, Keisha Robinson, Dr. Rosie Chang-Weir, as well as the San Diego COVID-19 Equity Task Force that was started by Dr. Rodney Hood, and again, Dr. Flalo, Dr. Jeanette Aldis, Dr. Happy Araneta, along with support from James Ellis at Scripps Research to help set up this webinar. We also have translators available in Spanish from Pals for Health, Ana Maria and Jane, and from 360 Link Solutions, we have Emily and Joshua providing Tagalog translation into your phone lines. So with that, I'll turn it over to our host for the evening, Keisha Robinson. Just one moment. Keisha is one of the members of our community advisory team, and she is, so she has been in the biotech industry for 20 plus years, and she is also the CEO and principal of a new diversity, equity, and inclusion company that will be coming live in San Diego in just the next few weeks. So I will turn the microphone over to her.
Good evening, everyone. Can everybody hear me? Thumbs up, we're good. I'm guessing that's a yes. All right, so tonight we will be discussing COVID-19, including the science behind vaccine development, clinical treatments, and local resources available for you to stay healthy and safe. We'll hear briefly from 3 experts in their fields before answering questions from the audience. Please submit your questions to the Q&A box. First, please allow me to introduce Dr. Andrew Ward, a professor in the Department of Integrative Structural and Computational Biology at Scripps Research. His lab focuses on immunotherapeutic and vaccine development to fight viral pathogens such as HIV, influenza, SARS, MERS, Ebola, and hepatitis C. Dr. Ward.
All right, thank you for the introduction, Keisha. It's a pleasure to join this group tonight and do some community outreach. That's, I think, becoming increasingly important, and in the day and age of Zoom, we can do that. And so giving the community access to the science, the physicians, and the community is a really concerted effort. And we all have roles to play, whether it's from the public health or participating in vaccine trials to fight this. So I'm going to give you a brief overview of COVID-19 and give you just a snapshot of the science that we have done and participated in, and just some thoughts along the way. I will say that Scripps Research has hosted now several called front row lectures along topics of other Scripps researchers that are publicly available at this website. So if you're interested in more of the scientific details, feel free to log on and check out some of those presentations, one of which I gave not too long ago. So I thought I'd start by just introducing you to some of the lab members. This is what the lab looks like nowadays. So everyone is wearing a mask. Everyone is practicing social distancing and taking extra precautions. So at Scripps, very early on, we adopted these measures in order to prevent transmission. And we sort of reduced capacity. Now we're at nearly full capacity in a sense, working in 2 shifts per day to reduce the density on campus. And one of the things that Scripps has done remarkably is set up its own internal in-house testing. So every employee on campus gets tested once a week using the PCR test. And so far, in testing thousands of employees, we've detected a couple cases, but importantly, there's been no transmission on campus, which suggests that the measures we've taken, such as wearing masks, are very effective at reducing transmission. And that's good because it means we can keep doing the research in the labs. So SARS is obviously known to be airborne now. And here's just a really sort of somewhat scary video of a group from Finland showing what happens when a person coughs in a hallway and how the aerosol and other droplets disperse. And you can see it covers quite a range, right? So this is why being outside and practicing social distancing is important in sort of to reduce your exposure. Likewise, for masks, they're not perfect, but worn in both directions, they can be quite effective at reducing the spread, right? So the heavier droplets will fall to the ground or other surfaces. You can get infected that way, but the main route of transmission is if you breathe in some of these droplets into your nasal passages or into your lungs. And so being an airborne disease, let me see. Okay, so we know a lot, and I should say this is interesting because it's a very active area of research. We're learning as we go, but we have quite a sophisticated knowledge in a relatively short amount of time. We know that once the viral particles enter the upper respiratory tract, they actually attach to these ACE2 receptors, which are in a lot of the cell types in your lungs and in your body. The virus then migrates to the lower lungs, and you get more and more severe disease, and these cytokine storms and related antiviral mechanisms in your body create a lot of tissue damage and lead to the more severe diseases. So that was known pretty early, but we're still making discoveries. A group at UCSD, Jeffrey Esco, just recently discovered that heparin sulfate on the surface of cells also acts as a co-receptor. So that plays a role in what type of cells can become infected. And so again, these are nice examples of how we're learning as we go, and we can build that knowledge into both therapies and vaccine strategies. Just another sort of advertisement, Scripps has done a really nice job with some really simple videos describing the anatomy of the coronavirus, the pieces and what happens during infection. And a lot of the artwork was actually done by a graduate student in my lab, Haley Parrott, making some really nice animations that are easily accessible. So again, I encourage people to check that out if you want to learn a little bit more. So antibodies are really the key to immunity and what we're trying to elicit during vaccination. So these Y-shaped molecules that are floating around your blood are really the surveillance that dampens infection. So if you look at a primary infection, as you get infected, that you get more and more virus. This is when you become the most infectious to other people. You're transmitting the virus. But antibodies then start to build up, recognize the virus, and as these come up, they start to kill off the virus. And that's a very normal process. And so we're learning a lot about patients and primary infection to coronavirus. And really what remains to be seen and what we're trying to do with a vaccine is such that if you get exposed to the virus, you actually make a lot more antibodies in a very short amount of time. So you have almost no symptoms and really no risk of transmission. And that's really the goal of most of the vaccine efforts here. And it's also, these antibodies are the other side of the coin in terms of testing. So people can test if you have antibodies to SARS-CoV-2, then you can assume that you were previously infected. So the qPCR test tests active viral infection, and the antibody test tests whether you were historically infected. So on the surface of the virus is something known as the spike protein. And the spike protein is really the target for all these neutralizing antibodies that we're trying to elicit with vaccines. And the reason is this is the protein that's responsible for recognizing the cells, recognizing the ACE2 receptor and the heparin receptor. And it's also the little micro machine that helps the virus get into your cells and infect them. So we really want to be able to hone the immune response very tightly to this protein here. And so here's just another schematic view of the virus, the spike, and then here's a nice atomic resolution picture of that spike. And we know even more now that antibodies, particularly to this purple part, or the receptor binding domain, are particularly effective. So again, we're able to learn quickly what the immune system is good at recognizing and good at targeting and eventually blocking the virus from entering your cells. So that's really the focal point of vaccine development now. So if we look at what's happened, it's really been an amazing effort by both public and private entities, and nearly all the efforts are built around ways to deliver this particular protein, this spike protein of the virus, to you in a vaccine formulation. So some are being delivered by nucleic acids, and then your body uses its own machinery to make this protein. We can also deliver that protein directly in terms of a recombinant protein vaccine. We can introduce that protein through other viral vectors or other sort of machines that can go and deliver. And then we can also do more classical approaches where we inactivate the virus itself and give that to you and expose you to the spike protein. And this is how the polio vaccine and most of the childhood vaccines you've had work. The reason we like these more sophisticated approaches or we prefer them now, is the immune response can be quite dispersed and defocused on lots of different targets. Whereas if you only give it the spike protein, then it can really hone in really quickly. The time frame of this has been pretty incredible. Of course, it's not fast enough, but talking about vaccine development in terms of months is quite unusual. We're usually talking years and tens of years, but each one of these parts of the pipeline are being improved, accelerated, and empowered by a lot of the basic research and technology and what's been known and done over the past 20, 30 years. And this is just another graphic to sort of impress upon you how many vaccines are being developed. So this is a little bit outdated by a couple months now, but you can see there's well over 100 vaccine concepts. Again, most of them delivering that spike protein. And then several have advanced to phase 1, 2, and now the Moderna vaccine and some of the adeno-based vaccines are on to phase 2, 3. So really large-scale efficacy trials in which the community becomes an integral part of testing in that science experiment. And I should say the good news is that all of the vaccine platforms, to one extent or another, in their early phase 1 or those that have been in phase 1, do induce neutralizing antibodies to the receptor binding domain, and they've all been shown to be safe in humans. So that's an important first step in any vaccine. And now it's really a matter of sort of discriminating the levels of antibodies that are elicited and how effective they may be and how long they'll be effective. And those are the large scale efficacy trials that will be coming up around the corner. And then just a little bit of the science and introduction to what we do in the lab. We solve atomic level structures. So a lot of the pictures I've shown you are the atomic details of that spike protein. We've been doing this for a number of years for a number of viruses. In 2016, we were working on a seasonal coronavirus, then when coronaviruses were still in obscurity. And what that structure showed us at atomic detail was where the protein could be stabilized and improved such that it would be more stable in a vaccine formulation. And we discovered that with colleagues at the NIH and at Dartmouth, that if we inserted these two P or proline mutations in a certain region of the protein, it resulted in a far more stable and easier to produce spike protein. And I'm happy to say that if fast forward to 2020, several of the leading vaccine candidates actually have incorporated these 2P mutations, and it's resulting in improved immune responses. And we're about to submit another paper describing our work actually with Novavax. And so this work done by Sanya Banguru, postdoc in the lab, where we looked at the actual vaccine candidate. It's a protein subunit vaccine. Sanya and colleagues in the lab solved the structure at high resolution. We were able to learn some new things, and importantly show that despite the huge rush at which this vaccine was produced, that it was done at a very high level of quality control, and it looks really good. And satisfactorily, last night, Novavax announced very positive phase 1 trial results in humans, showing elicitation of neutralizing antibodies. And so we now are sort of at the interface of the basic research and doing the sort of nuts and bolts research, and also working with companies to help them evaluate their platforms and vaccine candidates. So with that, I'll end and pass it on to the next speaker. Thank you.
All right, thank you, Dr. Ward. We appreciate all the additional insight. Next, we will actually have Dr. Michael Preziosi, who specializes in infectious diseases at Scripps Health. In addition to treating and managing infectious and tropical diseases, HIV and AIDS, he also works in transplant medicine. Dr. Preziosi.
Thanks a lot, Keisha. All right, so I'm going to talk a little bit about what the symptoms of COVID are and what treatments we have so far for it. So this is a little timeline here. Let's say, oh, sorry. Let me got to figure out how to advance my slides here. Go to, okay. All right, yeah, so a guy coughs on you, not wearing a mask, and we'll call that day 1, right? And for the first 5 days or so from the time you're exposed, you won't have any symptoms. That's what we call the asymptomatic period. And it's important to know that you are contagious, you are infectious while still asymptomatic, and probably the peak period of infectivity is a couple days before you really start developing symptoms. The initial symptoms are typically fever, cough, fatigue, low appetite, muscle pains, diarrhea. Some people will actually get a loss of taste and smell as the virus is replicating in the mouth and nose there. And it's also important to know that many people will never develop any symptoms. They'll still be infectious, but not develop any symptoms. And it seems that the younger you are, the less likely you are to develop symptoms. There was the sort of controlled environment of the USS Teddy Roosevelt. It was a bunch of young, healthy sailors that were quarantined at sea while there was an outbreak going on. And 20% of the people that were exposed never developed any symptoms. At about day 7, 40% of people who have symptoms will start to have shortness of breath. So beyond just the cough and the fevers, will actually start to have difficulty breathing. And in 1 out of 7 patients will develop severe illness and likely need to be hospitalized. And 1 out of 20 will develop critical illness and likely need to go to the ICU. So while it doesn't seem like a super high percentage of people that get infected, we are dealing with huge numbers of people that are getting infected. So that's why it can rapidly overwhelm hospital systems and ICU systems. All right. It's helpful to sort of think of the disease in a multiphasic way. In the early stage where you have either the no symptoms or the cough, fever, diarrhea. This is where the virus is replicating. And then the immune system kicks in, usually at about a week, and starts making antibodies. And either that immune response can be beneficial and sort of prevent the patient from going into that next phase, or it can run out of control, sometimes referred to as cytokine storm, where the whole immune system is just sort of going crazy. And the treatments that we have right now tend to be focused on one of these phases more than the other, either the viral phase or the inflammatory phase. So a few treatments that you may have heard of that are now approved by the FDA. One is remdesivir. So this is a antiviral drug. It was first used in studies of Ebola and the Middle Eastern respiratory virus. And it works by blocking the viral replication. It has to be given intravenously, usually for 5 days. And it seems to be most effective in patients who require oxygen, but are not yet on a ventilator. So it seems to be that it's more effective if you give it earlier while the virus is still replicating before that huge inflammatory response kicks in. I should stress that it's not something that we would give to people that are outpatients, people who are not in the hospital. It has to be given IV, it has to be monitored pretty closely. And I should also stress that it is not a silver bullet by any means. In fact, it really hasn't been shown to reduce the chance of death from COVID-19, but it has been shown to shorten hospitalizations and improve the time to recovery, which is actually very important when you think about how this disease can overwhelm hospital systems. If we can shorten people's hospital stay, that's a big benefit. Another drug that you might have heard about, which has been shown to improve the death rate in select patients is dexamethasone. And dexamethasone has been around for a long time. It's a very cheap, commonly used steroid. And this would be an example of a drug that is more active in that inflammatory phase. And in fact, the one large study that has shown its mortality benefit shows that its biggest benefit is in people who are requiring oxygen, but it might actually be harmful if we give it too early. And that just kind of goes to show how this is this multiphasic illness. Oops, sorry about that. And different drugs hit different phases. So if you give this drug that suppresses the immune system too early while your body is still trying to build that immune response, it might be harmful. But when you give it later, when the immune response has gone out of control, it seems like there's a benefit. There are some treatments that got a lot of press early on that don't seem to work. So there was a lot of promise from these early small trials that were not necessarily peer reviewed, or trials that just showed an effect inside of a test tube without showing clear effects in patients. And some of these early results were jumped on by the lay press and have been publicized. And it's certainly appealing that a drug that's been around for a long time that you could take as a pill might improve the course of COVID. But drugs like hydroxychloroquine and azithromycin have not been shown to work. There's some suggestion that they might be harmful. So this is a drug I would not ask your doctor for if you're starting to feel sick from COVID. Another treatment, sorry, I keep having, is convalescent plasma. All right, so plasma is the fraction of the blood that contains antibodies. It looks like this clear yellow liquid. And convalescent plasma is plasma that is collected from a patient that has already recovered from COVID. And so the idea is we are giving the antibodies of somebody who's recovered to somebody who is still sick with the disease. And studies show that it is safe. In fact, we've been using this treatment for over a century, since the Spanish flu of 1918. It's hard to really, pin down at this point whether there's a mortality benefit. It does seem that it is very safe and that there's a good chance it'll help people if it is given early. Scripps is taking part of a national study being run by the Mayo Clinic that has transfused over 50,000 people in the United States. At Scripps, we've transfused 260 people so far. And actually, since this meeting began, I've gotten messages for 2 more patients that I'm going to enroll as soon as this is over. But we're currently experiencing a shortage of plasma. A month ago, we were ordering it and it would come within 12 hours. Now we're having shortages and delays of up to a week. So if you have had COVID, if you have recovered and are asymptomatic and your infection was more than 2 weeks ago, you are eligible to donate plasma. You can go to redcross.org, you can go to uscovidplasma.org, or just Google, how do I donate convalescent plasma? And there's a lot of resources. So we really need the community's help with this aspect. This is a potentially life-saving treatment that anybody who has recovered from COVID can donate. So that's all I have about my piece. So I will pass it along to Dr. Wooten now.
Thank you again, Dr. Preziosi. Excuse me. Next, we will actually have Dr. Wilma Wooten. Dr. Wooten has been with the County of San Diego Health and Human Services for almost 20 years, serving as the, Health and Human Services Agency for almost 20 years, serving as the public health officer for the last 13. She has training in family science, medicine, public health, and preventative medicine. Dr. Wooten.
Just one moment, we're gonna fix the audio.
I'm sorry, I was on mute. So thank you and welcome everyone to the presentation this afternoon. In the 10 minutes that I have, I'm going to just go over kind of 3 large buckets, but the second bucket will focus on the request today focused on testing, tracing, and isolation. What we also want to provide the framework used to respond to the pandemic, then what actions and strategies were taken, and then that's where we'll discuss testing and tracing and isolation, and then what process have we used to engage and identify key stakeholders. So everyone is familiar, next slide, with Live Well San Diego. And actually, before the pandemic started, we had close to 500 partners. Building better health, living safely, and thriving are the 3 components of Live Well San Diego. And Live Well San Diego, just as a reminder, is a comprehensive, innovative, and regional vision. It doesn't belong to the County of San Diego, but it is a regional vision, countywide vision, that combines the efforts of partners inside and outside county governments or county government to help all residents be healthy, safe, and thriving. And all partners and contractors, to the extent feasible, are expected to advance this vision as well. So let's move on to the next slide, which is focused on, next slide, which is focused on the timeline. And this information is just added for a hip pocket, but just want to remind people that on February 14th, the county declared both a local health emergency and a local emergency. And then the World Health Organization declared the pandemic on March 11th. I want to fast forward to actually, within March, we also issued a stay-at-home order, which was followed by the statewide stay-at-home order being issued. And our T3 strategy was born in late April, and this focused on, again, testing, tracing, and treatment. And treatment is where we include isolation and quarantine. Another timeline that's not on here, but it is actually May 20th, was when the county issued health officer's order for facial covering, making that mandatory. In the next slide, I just want to briefly share with you the latest demographics regarding COVID-19 cases. There are 30,516 cases currently, and the circles are related to the age group of 20 to 49 years of age. That's where we find most of our cases. 59% of the total number of cases are in this age group. For gender, it's pretty much almost split 50-50, with 51% being female and 49% being male. There's 106 individuals for which we do not have gender information. For hospitalizations, that's been declining over the entire pandemic. Initially, it was close to 20%, but as we began to test more, the latest results is just under 9%. And of those that are hospitalized, of the 2,627 hospitalized, 662, which is as of August 3rd, were admitted to the ICU, and that represents approximately 2% of the total population. And then lastly, for deaths, as of August 3rd, we had 568 deaths, which again is almost 2% of the population. Now, on the next slide, I want to show some key information related to, this is our epi curve, and this information is presented cases by date of illness onset. And as you can see, the first box was when the state began to open up, and we were allowing in restaurant dining, movies, and other activities. Again, we were dialing up. And as we did that, we saw that over the next month, we started to see an increase in cases. The next box is actually, that was July 13th. That's when the governor dialed down. And that's where we are now, trying to strike a balance between economic viability and protection of the public health. All indoor activities now have to occur outdoors, whether it is dining or gyms or salons. Outdoor operations is now what is allowed. And basically, we are at this state until the governor states otherwise. Now, in the next slide, these are the various sectors and entities that the governor dialed down on. Most of these obviously are businesses: card rooms, restaurants and bars, family entertainment centers, wineries and tasting rooms, movie theaters and zoos and museums. On July 3rd, all of these businesses were ordered to close indoor operations statewide. At the bottom half of the slide, for the counties that were on the monitoring list, and we had been on the monitoring list since June 30th, by this point, the business on the bottom half were also ordered to close their indoor operations. The exception is for schools. If entities came off of the monitoring list and they have been off for 14 days, then 7th grade through 12th grade could reopen. Again, we are on the monitoring list. The only thing that could open now, even being on the monitoring list, is getting a waiver for transitional kindergarten through the 6th grade. So that's where we are with that. In my last time, I'm going to, my time available to me now, I think it's about 5 minutes. I'm going to talk about the focus of T3. It's one of the primary approaches that we use, including containment and mitigation and developing non-pharmaceutical interventions, which are related to our stay-at-home order, social distancing, and facial coverings. Sector partnership, I'll talk about that in a minute. That is leveraging Live Well San Diego and all of the partners that we have. Also identifying and aligning with federal and state data-driven metrics. And then we submitted a state attestation form on May 20th so that we could be able to open up further. So all of this information, actually the attestation form, if you go to the state's website, our form is there. And then if you go to our county's website, coronavirus-sd.com, you'll find all of our data. Now I want to go to the next slide and talk about our T3 strategy. T is for test, and the primary goal there is to make testing accessible to everyone. Tracing is a significant and important part of testing, and also is a priority identified by the federal government and the state. Actually, across the board, and we'll talk about that in a few minutes, we try to implement a health equity lens in all that we do, identifying locations that reach all communities for our testing sites, ensuring that our staff that are hired to do case investigations and contact tracing are represent the community and the population in San Diego that is served. And then the third component of the T3 strategy is treat. And here is where we provide assistance for safe isolation and other individualized services. And not only is it isolation, but it's isolation and quarantine. In the next slide, when we talk about testing specifically, on the left side of the slide are locations where testing or types of testing sites are identified. We have county drive-through, we have walk-in or walk-up testing sites. We also have a mobile unit, our Live Well mobile unit that goes around to various locations throughout the county. And then we have contracted with hospitals, a hospital for testing at our skilled nursing facilities, and we also continue to do that through our county staff support. And testing or providing testing assessments, and I apologize for the term strike team. We try to be trauma informed, and that should be testing assessment teams. And then lastly, we have first responders that are going around to various locations, particularly in the urban parts of the county. We actually obtained a waiver from the state so that we could change their scope of work to collect specimens so that individuals that are hard to reach in our rural communities and other vulnerable parts of the county individuals could be tested. Now the next slide shows various testing locations throughout the county. We have 23 sites operating as of this week, 8 of which are concentrated heavily in the southern areas of the county where we have seen our highest incidence of cases. If we go to the next slide, just want to talk about trace. Now, the process for tracing actually starts more upstream with the case investigator. Once someone has tested and they are positive, that positive has to be confirmed as a case by our epidemiologist. Then the epidemiologist, lead epidemiologists on various teams assign the cases to case investigators. And then the case investigators interview individuals. It takes about 2 hours. They identify close contacts. Those close contacts are referred to contact tracers instead of contract tracers there. And then we also recently, in beginning this week, will be deploying our promotoras to be extenders to our contact tracers so that they can go out into the community and try to find people where contact tracers have not been successful. And then the fourth category is related to outbreak investigators. We have a process to go through the various addresses of cases, and when we identify the same address, we look at that and do the investigation and work up to determine if that is indeed an outbreak location. So in the next slide, this is related to our isolation. When people are, case investigators talk to cases, and when contact tracers talk to those household or other close contacts, they are asked if they have a safe place to either isolate or quarantine. And if they do not, we have resources, and we call this the public health hotel, to provide a location for individuals to safely reside as they are working out their isolation and quarantine periods. Now, in the next slide, this is just a summary of some key metrics for our T3 strategy. To date, the 7-day average is 7,103. And our goal for being in stage 3 of the state's reopening plan is actually 2 tests per 1,000 population, and that's 6,740. So we are far above that goal. Then the 14-day average percent of new cases is 5.4%. The goal is to be under 8%. And then the total test is in the bottom left, and I'm having problems seeing. That's why I'm hesitating here. Anyway, if we go to trace, 60% is, actually that should be 70%. This is our 7-day average. We don't want to be below 70%. But we really want, the metric that we want to achieve is consistency to be at 90%. And the second one is 87%, our 7-day average of close contacts. We've been great with that throughout. We really want to be at 90 or better, so we will continue to work on achieving that. And then on the treat side, this is just a number of the 7-day average of individuals in our public health hotels is about 48 individuals. We have 1,280 individuals that have been or utilized the beds to date. So, and then the total number of beds that we have is 1,167 at this time. And then briefly, next slide, Nora. I made the comment before that we try to use and implement strategies through a health equity lens. Even when we were deciding on what the priorities for testing would be back in April, Nora, next slide, we made sure that we had a health equity focus. And if you look on the far right side, that's the priorities for the county at that time. We are updating these testing priorities, and this should be out at the end of the week or next week. But you can see here that we clearly identified the fact that we wanted to focus on vulnerable population, older adults, those in rural areas, various racial and ethnic groups, individuals with HIV, and those with underlying medical conditions, as well as Native Americans. In the next 1 minute, I'm going to try to get through the rest of these slides. I talked about the fact that we currently have 493 partners. We utilize or leverage Live Well San Diego and the various partners across 4 sectors, which is business, CBOs, or faith-based organizations, as well as governments and education. And we created 10 community, different community sectors and 13 subsectors so that we can conduct community outreach, get the word out, and help these various sectors respond to COVID-19. We also, on the next slide, created a Youth Emergency Readiness Ambassador Program, where we conducted a series of focus groups and listening sessions identifying the various vulnerable populations from, we worked with the Latino communities, individuals experiencing homelessness, adults, older adults and disabled individuals, refugees and immigrants, rural communities, and youth. And out of that came this Youth Emergency Readiness Ambassador Program. And the next slide, just want to leave with you information about how to reach our website. That website again is coronavirus-sd.com. And if you go onto the website, you'll notice that we have, the website can be transitioned to various languages. That's in the red box there. And safe reopening plan is at the very top, because as we were reopening, we wanted businesses to be able to obtain the information that they could use to develop their safe reopening plan. And on the right side, these are the various links or boxes on the website that can carry you to different sections. The first, at the very top left, with the stick pin, is all of our data. Then we have the testing page to the right of that. Obviously, it says testing. We have information about coronavirus, community sector support. That's related to all of the various sectors I've described. And then there's also information for health professionals and other resources from the federal, state, and local levels. So at that, with that, I'm just a bit over. I will stop, and thank you for the opportunity to share this information.
Thank you so much, Dr. Wooten. We will now be transitioning to the discussion portion of the evening, moderated by Dr. Jonathan Wosen. Dr. Wosen is currently the San Diego Union Tribune's biotech reporter. He holds a doctorate in immunology and has training in science and science communication. Dr. Wosen?
Yeah, thank you, Keisha. So before we jump into probably the most important part of the whole town hall, which is where you guys get to ask the questions you've been entering into the Q&A box, I'd like to run just a couple of quick polls to get a sense of who we have on the line. And so you'll see those questions come up, and I'll give everybody about 30 to 45 seconds just to answer those questions. So I will launch that now. Okay, we're going to jump to the third and last question. Okay, so thanks everybody for taking some time to answer those questions. I think we can jump into the Q&A portion. So I'll start off with a quick question for Dr. Wooten. This came up in the Q&A box. Where are we at in terms of testing capacity? So does the county have enough tests to test the people that need to be tested based on their risk? Where are we at in terms of supply and capacity there?
So that's a great question. And in terms of capacity, the county has a capacity that's gone up from like 115 up to 315. Now we're at 2,000. We have a contract with Helix. And but that's not the issue. We have capacity, but the issue is supplies. And that's not something we have control over. And that's why we modified our testing priority list so that it could prioritize those individuals that had symptoms and but also the contacts of the cases, and then individuals that are in vulnerable locations like skilled nursing facilities. So that priority list will come out either at the end of the week or the beginning of next week. So far we are, and as I shared on the presentation, the state's target is to achieve 2 tests per 1,000 population, and that is approximately 6,700. And as you saw, we are testing on average over 7,000 individuals a day. So currently, as long as we can have access to the supplies, and the supplies could be a myriad of different things. It starts at the very point of collecting the specimen to supplies that are running the test. So as long as we can maintain access to supplies, I think we are fine with our capacity. We are above our capacity, and just the rate limiting step is supplies.
Okay, thank you for that. And just to, as we're running a little short on time, I'll ask people to keep their answers as short as possible, but that was definitely pretty succinct. No, you're good. Question for Dr. Preziosi. You're talking about earlier what we know in terms of older adults generally being at higher risk than younger people. There's also been a lot of talk about pre-existing conditions. Could you just say a bit about what particular conditions seem to put people at risk of COVID-19, as far as we know?
Sure. Obesity, heart disease, pre-existing lung disease, diabetes is a big one. And, in general, the more comorbid conditions you have, the more at risk you are for a bad outcome from COVID.
Okay. And then for Dr. Ward, this came up in the Q&A as well. There's a lot of talk of getting a vaccine fast, right? Developing something at sort of warp speed. If researchers are going fast and faster than we have gone in the past, how confident should people be that any vaccine would be safe? And then just to add maybe a quick follow-up question, viruses often change. Is this virus changing enough where that might be an issue for either a vaccine or for people's natural immune responses, where if you recover from COVID-19, should you be concerned that next year it's going to change in a way where you're not protected anymore?
Yeah, so that's a great question. I think warp speed has a much bigger impact, I think, on the potential efficacy than the safety, in my opinion. And the 3 different viral platforms that have been in humans already have been shown to be very safe. And the companies themselves, even though they're moving fast, are taking measures to monitor safety. And many of these platforms have been in people before in one form or another in for different diseases. So they're just plugging in a different antigen here. So I'm not so much worried about the safety, but that will be borne out in time. And then I think in terms of the virus changing, there's not really been much evidence of drift like you see in influenza, for instance. So I'm optimistic that if we have an effective vaccine against SARS-CoV-2, it will be good enough for this round of SARS-CoV-2. That's not to say that it will be incredibly durable and couldn't come back in years later in a different form, but I don't think it's mutating at a rate to be concerned with.
Thank you for that. That question for maybe swing it back to Dr. Preziosi for a second. This is a disease where people have heard a lot about the importance of staying home, social distancing, but for folks who are living with a lot of family members, people from multiple generations, if a relative or somebody you're in close contact with happens to have COVID-19, or if you are that person, is there anything you can do in those sort of close quarters to protect yourself or protect the people around you? Is that possible?
Well, I mean, ideally, if you have COVID, you should be isolating from those people. Now, in instances in which that is not possible, I mean, mask wearing and social distancing and frequent hand washing really do make a difference. And, the attack rate within families that we've seen from the literature is not sky high. It's on the order of, well, I mean, maybe 15% on the high end. I don't know if Dr. Ward has read different numbers, but it's not, and it's probably lower than that. So there are common sense measures you can take if you are infected to prevent other people from getting infected.
Thank you. And then maybe a question for Dr. Wooten. What are we seeing at the county level in terms of what areas, what neighborhoods, what groups, zip codes seem to be, hardest hit by COVID-19, and what do we think is going on there? And what, just maybe in a short and sweet kind of sense, what is the county doing to deal with that? That's a complicated question.
No answer is short and sweet, but I'll try to do that. All of our data for cases is on our website by zip code. So anyone can go and find out where cases are occurring. Obviously, 61% of our cases are Latina, but individuals from that group and all other groups live all over San Diego. But if we look at our hot map or heat map, most of the cases are in the southern part of the county. So that's why we have tried to focus testing sites in that area so that we can increase access of testing to those that need it. And this is the website showing, that's just the race and ethnicity website for all of our cases. Another thing I wanted to say related to the last question is that if people can't isolate or quarantine at home, we have the public health hotel. And so we encourage people to utilize that resource.
Okay, got it. And maybe just to ask a quick separate question, this came up a bit in the chat. So I understand we're currently, the county is currently on this list of counties based on case number and other factors. What is it going to take to get off of that list and to get things like schools reopened and gyms, running indoors? How do we get back to that place?
Well, in one of the slides where I talked about what was closed, we are on the list because our case rates was elevated. That is going down. Nor if you can go to the closure. And as stated in the slide about the governor's closing businesses, all indoor operations statewide on July 13th, even if we come off the list, the only thing that's going to be able to open up will be schools. So we will have to be off the list for a total of 14 days, and that's 7 through K schools. I'm sorry, 7th through 12th grade schools. Right now, waivers can be accepted from transitional kindergarten through the 6th grade. That's by definition elementary school. So that segment of the schools can now open if they submit a waiver to the health department, and the opening date has to be at least 14 days from when the application, around when the application was submitted. Everything else that you see on this slide is under the jurisdiction of the governor. The governor will tell us when these entities will reopen.
Okay. And do we have time for any other questions? Maybe one of the organizers can speak to that.
Sure, let's try to squeeze in as much as we can, as long as the panelists still have time.
Yes.
Sure.
Okay, so we're still sort of in early August, but fall will be coming, and sort of the typical cold and seasonal flu period of the year will be coming. Do we have any expectation, and maybe I'll pass this to Dr. Ward, but feel free for anybody else to chime in, of how this virus is going to behave a couple months from now as far as case numbers and how many people are getting COVID-19?
So, I mean, I think it is going to be pressing in the sense that people are going to return indoors. In San Diego, it's less of a problem than, in other parts of the country. But I think as long as we have our social distancing, our masks and other practices in place, it shouldn't change too much. And I think this is why, awareness and outreach like this is so important, to just keep people vigilant. Because this isn't going away in the next couple months. We're in this until we have a vaccine, and that's probably, at least a year away from now.
Got it. And then maybe a question for Dr. Wooten. Someone was asking if we're currently still on a stay-at-home order, and maybe the reason for that question is that people are sort of moving out and about in some places, at least outdoors.
Mm-hmm.
So how does that fit with the fact that we have this stay-at-home order?
Well, we are still on the stay-at-home order. The governor has not rescinded that order. Individuals that are older adults, people with underlying medical conditions, those individuals are still recommended to stay at home as much as possible, unless there are essential actions or activities that they need to take. And I know it sounds kind of counterintuitive, opening up but still a stay-at-home order. It does, but essentially we are still under a stay-at-home order, except for those actions that have been approved. And actually now the actions have been kind of pulled back. So eating is essential. So I would recommend pick up or take out. That's one way. And if there is outdoor dining, certainly utilize that. Again, outdoor dining, but with the facility adhering to all of the strategies that we know help to decrease the spread. And that's, again, facial coverings. But while you're sitting at a table, obviously you can't wear a facial covering while eating. I would recommend that you wear it all other times. And then social distancing, obviously. Now, if you're at a table with your household members, social distancing is not needed because you are living with those individuals. And that actually goes back to, we were talking about isolation and if you can or cannot appropriately isolate. If you can, what you want to do is be in a separate room from the rest of your family, not only a separate room, but a separate bathroom, not using towels, the same towels or other items, just really separating yourself. And if that's not possible, like go back again to our public health hotel rooms that are available, that are at no cost to the individual. And again, I know there was a question asked about tests. Tests are at no cost to anyone who is being tested based on our prioritized list.
And we still have time for more questions.
Did I answer the question? Because I know I threw a lot of different questions in there,
Yeah, I think so.
or answers.
Yeah, and then let's see. So for Dr. Preziosi, maybe to go back to the fact that this is a disease that most people recover from, without needing medical intervention. But why does it seem to be that some people have little to no symptoms, although may still be able to get others sick, and then some people end up having major difficulty breathing? Does it come down to pre-existing conditions and age, or do we have, is that picture getting any clearer 8 months into this pandemic?
Well, I mean, it is kind of the million-dollar question, why some people get so sick and some people don't. I mean, clearly there are risk factors, but, we've seen perfectly healthy 30, 40-year-olds get extremely sick from this virus. And we have not cracked that code yet, but I have never seen so much science advance so quickly in a 7-month, 8-month period than I have in my entire life. So, we'll eventually figure that out. But I don't think we've cracked the code just yet.
And maybe a question for Dr. Ward as we look ahead, and this might be a segue to the next session on vaccine trials, but somebody wanted you to basically speak to the importance of making sure that the group of volunteers that participate in these trials really reflects all the broad demographics of the country. If you could just say a little bit about the value of that for any COVID-19 vaccine study.
Yeah, so I think it's hugely valuable. Clinical trials are complex to begin with. And if they're done in a narrow population, there can be other factors that play a role. So it's particularly with all of the different platforms being tested, it may be that one performs better in different type of population. So representation from a diverse set of ethnic backgrounds is going to be really important. And again, the science will be powered because these are going to be large efficacy trials. And I think also it'll also hopefully build culture around that vaccines are safe. I mean, they're the safest intervention and save the most lives of anything we've done in medicine, ever. And we should be embracing them as communities, and hopefully, activating people to take part in this process and being inspired. So I really do hope that this is an opportunity for those communities to engage, contribute, and embrace the work that's ongoing.
Well, that might be a good note to end on. I know we had a lot of questions that we couldn't quite get to. We're going to be holding on to those and answering them in advance of the next session. But yeah, so I want to thank you guys for posing those questions and let you know that we will be getting to them. And then I'll pass it back off to Keisha, actually, at this point.
Thank you very much, Dr. Wosen. Can everybody hear me? Hopefully. Thank you all for attending tonight's town hall and just taking part in this very important conversation. We wish we could have gotten to a lot more of the questions, but there definitely will be a continuation on the next one. You will be directed to a brief survey to help us understand community needs for COVID-19 and how to improve this event. So that should be showing up now for you. There's information to click on there. So there's a link that you see on, well, there are several links right now. You also have it in multiple languages. So there's a link that you can click on to answer these questions. Also, we would love if you could join us for our next community town hall, which will be on next Tuesday, August 11th. If you look on your screen, you'll see all the physicians who will be on this call. Will be Dr. Happy Araneta, Dr. Jeanette Aldas, Dr. Christian Ramers, and Dr. Camila Nebeker, all of either San Ysidro Health or UCSD and Family Centers of San Diego. And that will be next Tuesday, August 11th, from 5 to 6 p.m. And we will basically be discussing the risks and benefits of joining local clinical trials for vaccine trials. If there are any questions, please feel free to continue to drop them in the Q&A. We will answer them as we can. Also, a lot of the information that you would like to see is available online at the Department of Public Health. Thank you again for joining us for this town hall, and have a good evening.